Perfect. Awesome. So again, there's our little title screen. And I've already said this to Erica and Elaine. Shout out to my wife. I don't know if she's on or not, but she designed all of this PowerPoint stuff. I'm not the tech one. So bear with me as I kind of struggle through. But yes, again, my name is Dr. Case. I am a doctor of chiropractic and a diplomate of the American Chiropractic Neurology Board. So from all those syllables, if you've never heard of that, you are not alone. We are a very, very specialized field that focuses primarily on conservative care. And we'll kind of dissect this as we go, which means we do not perform any surgeries on site. I don't prescribe medication. We are a complementary service to those patients that are coming in with a pre-existing condition. We'll kind of dissect that one as we go forward. And again, a lot of the kind of novel things that we do here that's my goal for the end of hopefully by the end of this, you'll have a little better grasp on that. Just a quick background again, I did get my bachelor's degree, in biopsychology, which kind of started me along my neurology performance, if you will. I got my doctorate in chiropractic from Palmer College of Chiropractic. At the same time, I got the Diplomate Carrick Institute, ACNB, all the fun letters that go with that. Basically, my wife calls me a nerd, and I'm okay with that. I like being a nerd. I think it's kind of fun for me, and my patients tend to like that as well. I like to be very involved with a lot of the patient outreach things, including the American Chiropractic Association, the Georgia Association. And then if you're curious at all, we have a handful of published case studies in the frontiers in neuroscience, which have been presented at the ISCN, a bunch of fun, nerdy neurology stuff that myself and my colleagues do together on a yearly basis. And then I'll give you a little bit background about myself and the practice. So we don't do as much of the research end. I love that I was able to jump in on Dr. Oken's speech last week or 2 weeks ago. We're kind of the other end. And what that means is we are a solo practice. You can see a photo of my team. And yes, that is pre-COVID, as you can tell. No, the Chick-fil-A cow is not part of my team. That was on an autism 5K run fundraiser that we took part in, but we do provide specialty care. What that means, I'm a solo practitioner. I do all of my therapies hands-on myself. We provide general chiropractic, more of the functional neurological approach, and then neurorehabilitation, as well as functional medicine and supplementation. So my goal with every patient, every visit, regardless of what they come in for, is to figure out why they're experiencing what they're experiencing. So we go on a very, very hard individualized approach for that human system, whether it's brain, body, blood, structure, function, whatever it might be. And then another quick background in terms of things we tend to see, and this myself and my colleagues do along the realm of functional and clinical, chiropractic neurology. We treat things along the lines of brain injury and impairment, balance disorders, pain disorders, developmental, and then what we're here today for, of course, is the Parkinson's disease, so neurodegenerative disorders, Alzheimer's, dementia as well. So what is chiropractic neurology? Which is what every patient says when they walk in the door, like they've never heard of this. That's, again, totally fine. To my knowledge, I think there's still less than 1,000 in the United States that hold this certification. It's a very specialized field. If you've heard of the field of functional neurology or clinical neuroscience, it's all the same thing. So again, we do focus on the diagnosis and treatment of disorders of the nervous system. So it's a very, very umbrella term. What that means, though, is we use proper diagnostics, different exam procedures, and a very in-depth history to figure out more of the function of the human system versus the structure. And that's what we're going to kind of dissect as we go forward. So again, the foundation of chiropractic neurology is that it is non-invasive, right? We do not use drugs or surgery. We are complementary, which means we co-manage. And I'm very passionate about the multidisciplinary approach because if any doctor says they can treat everything, I'd like to meet them. That's a pretty cool trick. But nonetheless, I think our best approach with especially cases like Parkinson's disease is that co-management. And that's really what we want to push for. So if you've ever heard of it, the science, if you will, of what we do is neuroplasticity. Now what that means, I like the middle one here. There's a bunch of different definitions. Neuroplasticity generally is the brain's ability to change. So if you look at that middle one there, that's my favorite, the ability to modify, change, and adapt both structure and function throughout life and in response to experience. The way we like to look at this, again, structure versus function. If I take an MRI of a brain and the brain looks perfect, but that patient comes in and they still have dizziness or tremor or spasm or constipation, it tells me that something in that brain isn't functioning as well as it could be. And that's really where myself and my colleagues like to step in. I'm not going to necessarily change the structure of that brain, but if we can take what's there, apply the appropriate rehabilitation to that zone of the brain, if you will, to those neurons, we can improve the function of the structure that's maybe not doing what it's supposed to. And we do that with various techniques using eye movements, sensory motor techniques, electrical stimulus, vestibular therapies, what have you. In terms of neurodegenerative disorders, right, especially Parkinson's, when we look at neuroplasticity, you can break it down into positive or negative. And what that means, negative neuroplasticity, you take a patient, give them a roll of Oreos and a pack of cigarettes and sit them down in front of the TV, their brain's it's probably not going to promote brain health, right? That's negative neuroplasticity. That brain's probably not going to function as well as it could. It's not going to be up to its capacity. Positive neuroplasticity on the flip side, I take that brain, we take away the Oreos, right? We take away the TV and the cigarettes, or to say it differently, promote proper lifestyle, proper nutrition, diet, rehab, everything that goes along with human health, that brain can then change for the better. So that is the foundation of what we like to do for our patients. Take what's in front of us and make it work better. And we can do that very, very simply. The reality is it takes a lot more work on my patients than it does for me, but that's why I'm so passionate about patient care and involvement, because it's definitely a group approach. So we'll go a little forward here. Some of you have probably seen this illustration before. I hope so. If you haven't, they call this the blind doctor, right? So what you can see, you throw 1, 2, 4, 6 doctors up against an elephant that are blinded. They're all going to look and think it's their own opinion. So when I take this approach with a patient, this is the novelty, in my opinion, is the individualized approach. What that means, if you line up 5 patients with whatever condition they might have in front of us, I need to look at each patient differently. They all come in with the same diagnosis. I probably shouldn't treat them all the same because they're not the same person, right? So when I look at this, let's again, for instance, with our group here with Parkinson's, I don't want to look and say, well, I probably need to send them to an orthopedist for shoulder pain, or a gastroenterologist for their constipation, or an ENT for loss of smell, psychiatry for depression, maybe eventually a neurologist for tremor. We need to pull the reins and say, well, why do they have that shoulder pain? Why do they have constipation? Where did that loss of smell come from in that brain? And take the umbrella approach to look at the individual, including their mobility, their eye movements, coordination, what medications they're on, how their cognitive self is, their executive function, emotionality, and at the bottom there with that big old asterisk is overall function. And you can start to see the trend with this. Because in our office and in many of my colleagues' office, and that's what I want the patients here to know, to take that individualized approach takes time, it takes effort, but it's available, right? We know a lot more than we did 5 years, 10 years ago, especially 20 years ago, and the importance of these things. And we can use the current research in terms of gait and balance and eye movements, some things that I'll be speaking on here, to better triangulate the part of the brain that would probably need to be rehabbed. Or we'll use gait for an example, which is just a fancy word for walking. And I'll kind of come to this next one. When we do a gait analysis on a patient, and you can see all of the differences with somebody walking. Well, if I have a patient in front of me who doesn't swing their right arm when they're walking down my hallway, or another one comes in and doesn't swing their left arm, I probably shouldn't treat those patients in the exact same manner. Now, for me, same thing, we'll use tremor as an example because everybody's pretty familiar. If I have a tremor of the right arm, we know where that is in the brain. We have that pretty well triangulated. Or patient B comes in with a tremor of the left arm, I'm going to take a different approach in my neurologic therapy to that patient based on that area's brain or that brain's area of dysfunction. So again, we're just kind of putting the pieces of the puzzle together, if you will. Or again, with walking, if somebody walks in and says, well, I always stub my right toe or my left toe, whatever it might be, we have to take that into account in terms of our triangulation or our identification of that brain's dysfunction. And what you can see here, we have 1, 2, 3, 4, 5 different types of walking compared to normal. And we would treat each one of those patients differently based on that individual presentation. And that's really, really the approach I like to push for most patients. So we'll keep going forward just as another quick example here. I have balance and posturography. This is one of our specialized tests that we do like to offer. There's plenty of different ones out there. We keep one on site here for all of our patients. Because again, in terms of walking and balance, right? We know, especially with Parkinson's, that fall prevention is key. We know that is one of the most incapacitating issues with a Parkinson's type patient is a fall. They're dangerous, right? Bottom line. So fall prevention is of the utmost importance with any patient that walks in the door, but especially those that have a predisposition for such dysfunction. So what we can do with different types of testing is say, okay, what are their limits of fall? Do they sway towards the right? Do they sway left, forward, back? To what degree? And again, those differences are going to guide the appropriate therapy for that patient. Or to say it differently, I can't just assume that somebody who doesn't have good balance should get the same therapy as somebody else who doesn't have good balance. Or if I sway right, or if I sway left, we're probably going to approach that therapy a little bit differently. Now, with that being said, I understand not everybody has this, but again, it's the education that this is out there, the conceptualization, if you will, of the individual approach to that patient's care. Because I know there's people out there right now that are sitting down saying, well, you're right, I do trip my right foot every time. Maybe that takes a little bit different approach in terms of their therapy in comparison to somebody who's out there tripping their left. Because again, number one thing is safety of the patient, but more importantly, what we'll get to show you here is improvement. And that's a word we don't often hear within this kind of diagnosis. And it's not one that I throw around lightly, but we have seen it. We know that we can take a patient with a diagnosis that is technically untreatable. We don't have a cure. We all know that on site right now. But what we do know with these kind of approaches, right, this diagnostic and then the individualized therapy, we can create change in the brain to take what's there and make it work better. And that's what I become so passionate about with my patients, is to say, well, they're coming in with a symptom. It's not one of those where I want to say, let's see in 6 to 12 months and we'll monitor the progress. I'm the type of clinician that likes to jump in between that 6 to 12 months and say, well, what can we do with what we have? Can we make it improve? Can we make the walking better? Can we improve their balance? Can we improve their gait? Can we improve their mobility? Is that something that needs to be done with nutrition or with vestibular therapy or whatever it may be? But looking at that patient saying, well, you're not necessarily stuck with what's going on in front of you today. Now, we know there's not a cure. We don't have one. The research is very, very beautiful out there in terms of this comprehensive approach, but the individualization of that comprehensive approach is where we really get to see the fun outcomes. Now, I will show you this next one here. I'm going to leave this up for a minute. I want everybody to take a look if you can see this well enough, and I'm going to grab my laser pointer here because this one's pretty important. What you heard made mention of earlier is eye movements. Now, this is one of those things that everybody looks around and says, like, never heard of it, right? Not many people, not many clinicians understand the importance of eye movements because for the longest time, we didn't have the technology to understand what we knew. All of this is baseline neuroscience back 100 years ago. But luckily for us, especially from the 90s on, the research and the diagnostics have caught up to show how we can use eye movements to monitor brain function. Now, if you look here on the left-hand side, for any other clinicians out there, you'll probably want to look at the bottom stuff through here. For any patients, any family members, things like that, if you can just look at the top, what this test here does is 3 different kinds of eye movements, slow eye movements, fast eye movements, and then staring at a dot on a screen, simply put. Well, we know with this kind of testing, it's around 33 different areas of the brain that have to be functioning appropriately to do these tasks correctly. So it's kind of like taking a gait analysis and putting it on a graph, but now we're using eye movements. So what you can see over on the left-hand side, I believe this was an Olympic athlete, so a very high-functioning, a well-functioning brain, fairly asymptomatic, but I also like it because he only got a score of 97, right? Harvard proved it a few years ago that our brains are inherently errored. We know that we cannot be perfect, which probably hit a couple of egos, and I think that's okay. But nonetheless, everybody is prone for error. Everybody has something not perfect up there. Our job is to find that imbalance, rehab it to as little symptom as possible, and then go forward from there. Now, what you can see on the right, and this is a pretty big difference, this is a more extreme case of Parkinson's disease. So this is the example we like to use. What you can see here, simply put, this is just tracking a target from left to right. Just follow a target left to right. And what you can imagine, if you put yourself in that patient's shoes, if it's really hard just to look around with your eyes in comparison, you're probably not going to have good gait. You're not going to be able to walk straight. You're going to have trouble with your mobility. because these different eye movements correlate to the part of the brain that control muscle and joint and cognition and emotionality. So what we're starting to learn is that we can use the eye movements both diagnostically and then more importantly, therapeutically. And again, these are just the baseline things that we could run. I'm not going to run an MRI on that patient. I don't need to. That's usually already done, A. B, I'd much rather take a look at this in front of me to see how that patient is functioning. What do they feel like, right? Put yourself in their shoes and say, well, this person's probably having a little bit harder time. What can we do? What areas of the brain do we need to provide therapy towards to then rehab them back to as best function as we can, progress or stability, whatever it might be, or the reality is we want to slow the progression of the disease as best as possible. And with current research, that's all we know right now, but we know that can be done, and we've seen it. With that being said, I'm going to give you a quick case study here. I don't want to talk too long, but I do just want to show you with this one. This is actually a patient of mine. Let me see if I can click through. My apologies there. My laser pointer's still on. Good. So I'll show you this page here. Now, what we have, I can't give any specific details, but this was a patient with confirmed Parkinson's, DAT scans and all. She'd been diagnosed, I believe it was 2 years prior to coming to our office, came in with just kind of hopes of getting some diagnostics run, some really basic stuff, nothing of any importance. And what we can see here, and I'll get my pen going again, up in day one here, baseline score 46, not too bad. She was functioning, she had some issues. Of course, we're gonna work on those. But why I'm so passionate about this case study is you can see the progression, or more importantly, to loop it all in, you can see the positive neuroplasticity that occurs. So we did our re-exam at about 12 weeks, right? Some pretty active therapy in there. We see a jump from 46 to 53. Already my clinical tail is wagging because we know that that brain's getting better. This is objective diagnostics. We can see the scores improving. We have, of course, the subjective, and this goes beyond just our UPDRS scales or timed up and goes and these, drawing your Archimedes spirals, or if some of you have done these tests, these baseline things that, yep, it's still good, it's still bad, whatever it is, move on. We get to look at the overall brain function using diagnostics and therapies like this. And again, we run the test at 10 months. You can see the improvement is 69 out of 100. And then the big jump there, 1 year, 9 months later. So this patient's basically been put on a maintenance program with us. We see her about once a month, once every 6 weeks, just to monitor, change home exercises. You can see 1 year, 9 months later, she has gone from a score of 46, very symptomatic, all the way up to an 88. Now, why we get so excited by this case, and again, why this is a case study versus research paper, because again, not many of these out there that are happening, but we saw an objective improvement over a 1 year, 9 month span for somebody with a progressive neurologic neurodegenerative disease, which is a pretty profound statement. And I like to show a lot of my patients this case study to restore hope, if nothing else. My rule with every patient is there's never nothing left to do, whether it's here, whether it's home, whatever that might be. Now, with that being said, this patient had a very extensive homework session, right? She had a lot to do. A lot of this happened outside of our office. And what that means, from day 1 to 1 year, 9 months, the brain can change. Now, we had her implement things like dietary changes. She definitely started exercising, right? We know the research supports that. 35 minutes a day of aerobic exercise at about 60 to 70% of your heart rate max can show increase in neuronal connectivity in your memory centers of the brain. That's not opinion, right? We know the research supports that. And these are the kind of things that we can incorporate for each patient. Now, of course, based on this one, our therapies are different. The home exercises are different, but there was a long history. And you could see in that first 12 months, not a huge jump. But what we see is as that brain starts to stabilize, we can encourage that growth. We can encourage that positive neuroplasticity with things like exercise, breathing, a lot of fun research on Tai Chi. And I know sometimes they'll sound a little trivial, but I promise you it does well. It's just a matter of applying those things. But again, the number one thing is that you can improve the function of your brain, right? And that's the big take home, that most patients walk the door and say, well, yeah, I was told to come back in 6 to 12 months and we'll see how much worse it gets. My job is to take that out of their vocabulary, let them know there's something more that can be done, most of which is going to be done by the patients themselves. and that it takes time, right? This is not an easy process, but it's pretty profound to know that you can objectively change how your brain functions, especially with conditions like this. So again, that is the overarching theme of this kind of realm, that conservative, complementary, and mind you, with this patient in specific, we didn't change her medication. We didn't change any other home therapy recommendations. This was a complement to that, right? My job is not to remove medication. Dr. Oken did a great job discussing that. That's not it by any means. My job is to allow that brain to function at a more efficient rate to slow the progression of degeneration. And that's really the approach we like to take with each patient every time we see them, whoever may walk through that door. It's a very active process, but it can be done. And that's why I wanted to show you this case today. Remember, there is never nothing left to do. The brain is a beautiful enigma, an enigma that it is, but it wants to heal, right? The brain wants to do better. We just have to apply the appropriate therapies, the appropriate recommendations to allow that to occur. So again, I do want to thank everyone for allowing me to speak briefly today. If nothing else, again, I hope I've inspired hope. That really is my goal for every patient, if nothing else. I hope I can answer any other questions, things along those lines. I know it's like taking a sip of water from a fire hydrant, a lot of novel concepts, but again, the education that there's more out there, right? Never stop your search, never stop your progression. There's always something else to be done. So with that, I do thank you again, especially to Erica and Elaine for having me on today. I really do appreciate that, and I'd be more than happy to answer any questions that people may have.
That was so great. Thank you, Dr. Case.
Well, thank you. I appreciate it.
I have a question myself.
Yeah, absolutely.
It's almost like when I think about like everything that you just went through from an OT perspective, it reminds me of like almost like a lifestyle redesign approach.
Mm-hmm. Yes.
And like, what are like some of the, well, I guess you send them home with homework, but what do you have like an example of homework?
Sure, absolutely. A lot of times when we take a new patient, I start pretty general. Most patients are going to end up getting some sort of exercise program, some sort of breathing routine, some sort of dietary recommendation. If you think of this cell and if some of you might have heard this analogy, you picture the neuron, which is our cell of the brain, as a three-legged stool. It needs glucose, which is the food you eat. It needs oxygen, which is the air we breathe. And it needs stimulus, which is going to be the lifestyle that we live. So I like to start with the foundational approach of encouraging appropriate nutrition, appropriate adequate water intake, adequate exercise, right? That 35 minutes of aerobic, encouraging those specific things to each patient allows that foundational treatment to really take hold. Now, once we dive into a little bit more in the individualized approach with our therapies, they'll end up getting things like eye movement therapy. They'll get their own sensory motor techniques, whether it's the movement of a limb, a balance therapy perchance, whatever that might be in concomitant with that. But most of my patients, we won't really graduate to that level until we know that they've started to implement those foundational things.
Right.
Mm-hmm.
Thank you.
Yeah, absolutely. Absolutely.
Excellent. I have a question, if I may, Dr. Case.
Of course.
So I love the example with the eye movement, right? Because sometimes that's really not something that we think of, say with Parkinson's disease or even essential tremor, because we see the tremor, it's so obvious and it's on these limbs out here, but the eye movement is real, and so I really appreciate you pointing that out. And one of the things I was going to ask you, so you told us about the eye movement and the way that you were able to actually quantify it with a number, right? It's not just the patient saying it's better. What about some of the other movement features associated with like Parkinson's disease or essential tremor? Are you guys able to do a similar kind of thing with, say, with hand tremor or?
So at least to my knowledge, we don't have as much in grading the tremors. Now we know based on speed and rotation, if you will, which axis the tremor's on and how fast it is, you can grade what part of the brain it's coming from, whether it's 4 to 6 hertz. So if you can know the hertz of a tremor, the reality is it's by observation, it's very difficult. So you can tell different, is it a red nucleus, is it from the basal ganglia, wherever that tremor is really originating from. The good stuff is with tremor, we try to reduce them pretty quickly. We know where there's only so many areas of tremor is going to arise from. If it is that, without getting too sciencey for some of the participants, if it's the basal ganglia or the midbrain, whatever it might be. But again, in terms of our functional approach, Our job is we can take those eye movements because they incorporate those same areas that cause that tremor, right? That's like, if you're curious, I can send you that one. But the ability to just look between two targets goes right through the basal ganglia. It goes through the same area of the brain and brainstem that triggers tremor. So if I see tremor, I can assume that that portion of the brain is involved based on that kind of examination. We can do the eye movement testing, and a lot of times too is the vestibular testing, that bounce that you saw, and we can really triangulate those parts of the brain that are triggering the tremor in the first place.
So
that's kind of, go ahead.
I'm gonna say, would it be fair to say that by targeting the eyes, because you are able to quantify it so well, you're actually also targeting other parts of the movement symptoms, right? Like the tremor and the gait. So
yes,
while you're just quantifying the eye, you're actually treating the other things as well.
Absolutely. And that's when we work, like you said, essential tremor, the last thing I'm going to do is touch that tremor. Put that arm to the side. I'm not going to worry about it because we can't, if it's already overactive, which it's it's a hyperkinetic movement disorder. The last thing I want to do is stimulate that part of the brain because it's already overactive. And that's really the approach we like to take is if something, for instance, with Parkinson's, the loss of dopamine, we don't necessarily want to throw too much at that exact part of the brain because it's already overstimulated to the point that it's breaking down, right? That's that pathophysiology. So what we like to do is take the other parts of the brain that maybe inhibit that area, right? Or maybe activate an area that then inhibits that area. And we can start to use these downstream therapies to reduce that excitotoxicity, right? For lack of a better term, that overactivation, that overstimulation. And we do this with eye movements, with balance therapies, with sensory motor techniques. Just it's the knowledge of where those different eye movements go in the brain, or what they activate more accurately.
Fantastic. No, it's so fascinating to hear the different approaches that you take from what I think many of us associate with traditional chiropractic medicine, right? Like who knows, you're actually changing the way that the brain is organized. So,
absolutely. That's
very cool.
That was what really got me inspired with the neurology realm is, going through chiropractic college, and not to, if their DC's on, not to knock any, but we would say, all right, this adjustment's going to affect the brain. And I would raise my hand and say, where? It usually got pretty quiet from that point. So I want to know if we're going to do that kind of stuff, I should probably know really what's going on. And that's why with the chiropractic realm or the functional neurologic realm, we use that as a tool, right? The chiropractic adjustment or manipulation. We know where these different inputs go to the brain. We know what they activate. Our job is to say, should they be adjusted? Should I adjust a pinky or a neck, right? It's a very, very different input to those different neuronal pools of the brain. I tend to not adjust most of my Parkinson's patients because there's usually a degree of overstimulation that's already occurring, right? We don't want to promote breakdown. We want to promote slowdown, if you will. We want to inhibit that breakdown. And it's a lot of the different techniques that we just spoke of. Yeah.
Fantastic.
A little different approach, I know, but I'm pretty excited about it for this one. Again, that's why I'm so passionate about it, just educating, because most people don't even think of eye movements, right? And it has nothing to do with visual acuity, right? I'll send out to optometry for that. Ophthalmology is great. This is more neuro-ophthalmology, if you will, if you want to get into that realm. But again, it's the functional neurology, right, in and of itself, getting the brain's function to improve. And that's really what we go for.
It almost is like mapping the brain through the eyes, right?
Yes, very much so. Very much so.
Very cool.
Yeah.
If anyone else if any of the attendees have any questions that you want to add to this, please feel free to put them in the chat. The chat box is kind of at the bottom if you hover your mouse over that. So just throwing that out there one more time in case we have any.
I'd be happy to answer any, so absolutely. And again, I did put the contact information for any participants. If you have questions, there are a handful of us around the country, right? So if you have family members, anything like that, if you're always looking for answers, please reach out. I'd be more than happy to answer anything we can for you. I really do mean that.
And I believe Erica can share your contact information as well in a follow-up email with the attendees.
Sure.
So we'll make sure
I'd be happy to help.
They know how to find you.
Yeah.
I can do that.
Wonderful. Wonderful. Wonderful.
All right. Well, should we move on to the affirmation, Erica? And then if anyone does have questions come up, we will certainly grab you, Dr. Cates, before we end.
Yes.
I'll stick around.
Yeah, hang around. This will be good to have you participate with us.
All right. So we always end with the affirmation of the day. And today we have I am love, I am purpose, I was made with divine intention. And I hope that everyone leaves with that mindset. And I hope that you enjoyed today's talk. And I'm very grateful for each and every one of you. And I hope that you know that y'all are all loved and made with purpose and that you all have your own divine intention. And we have upcoming speakers. So on March 18th, we'll be doing a LSVT Thinking Big session with Elizabeth Gerdes. She's a physical therapy assistant. And on April 29th, we're going to have Iman Ali. She's a Reiki master therapist, and she does the science of sound plus energy medicine. So I'm very interested to see all of that good stuff. And I I hope that you all will join, and I thank y'all for coming today. And if you have any questions, please feel free to stay on. If not, I thank y'all.
Thanks, everyone. Thank you, Dr. Case.
Yeah,
Thank you,
absolutely.
Dr.
Again, thank you for having me. Absolutely. Absolutely. We're happy to help.
Thank you, Erica.
Thank you.
Yeah, and Elaine, if you are curious about those eye movements, also I can forward you that one.
I am. I have a
it's a-
couple other questions I'm gonna send to you
Yeah.
as well. Okay.
Yeah, not a problem. It's a messy spider web just to like look at a dot. You know,
Oh, I
it's
can
pretty
only
fun stuff.
imagine. It's really cool that you're able to quantify it. I
Mhm.
love it when you can quantify movement. You know,
Yeah.
like it's not this subjective thing that somebody sees.
Mhm.
That's the trouble we run into in the clinic with tremor and even gait. You know,
Yeah.
it feels better, it feels worse. It's like, well, what does that really mean? Like,
Mhm. Yeah, and
so
that's, I think, especially with gait, of course, the vestibular testing, the balance testing is the way to go. And there's some really affordable machinery coming out now, which is great. It used to be pretty prohibitive, but
yeah,
in terms of the research realm, it's caught up, in my opinion, especially in the last 3 to 5 years with the eye tracking technology. And mind you, this is more eye tracking. The other realm would be considered VNG, which is more in the dark, just a little different in terms of the concepts, but all of which are graphed now, right? We can
yeah,
see baseline, we can see the improvement. More importantly though, is you saw with those examples, it really lets us triangulate right frontal lobe, left frontal lobe, basal ganglia, where in the basal ganglia it's involved,
right.
without having to do any other, we don't have to run an FMR on every patient that walks in the door, right?
Yeah, that would be costly, prohibitive.
Yeah, just not realistic. It's not. So that's why we get so excited that these things can come out and we can have them on site. That test that you saw took 3.5 minutes.
Yeah,
That red eye test. So
I don't know about you, Erica, but it makes me want to go get a test.
I
I want to know what I want to know what my brain IQ is. I think it's probably like 97, just like the Olympic athlete.
there you
But
go. I've seen 199 and I was impressed. I thought he cheated, but you can't. So
yeah,
yeah, no
but
such thing as 100%.
no, not yet, anyways, right?
Not yet. Not
Well,
yet.
have you tested yourself?
Yeah.
And
Yes.
are we allowed to
Oh,
know what it is?
I think last time I tested, I was at like a 93,
Okay.
somewhere in there. So
So
it's
do you
variable.
follow it to make sure, you
Oh, yes.
identify it if it starts to
Yeah.
drop?
I've been running these kind of tests with me for about 5 years.
What about your wife? Does she let you test her as well?
She actually jumped on. So
Oh, she did.
I'm
Hi.
not gonna, yeah, she just jumped on. I saw her name pop up there. Yeah, there she is. Yeah, she
Okay.
just said
Oh,
hello.
hi, Emily.
I don't know if we have, maybe when I first got the device, I'm sure it was like 101, if not higher.
Of course, definitely. Yeah,
If my memory serves, right?
right. It's probably gone up now to like 105.
Yeah. It's a new norm now for her,
That's
right?
right.
That's it. That's our comparative.
I like it. I like it.
Yeah. Yeah.
Perfect.
And then that's the eye movements are just one piece of the puzzle. We like the gait analysis. I really like the posturography. I was going to put up a video. We do look at infrared goggles too. So we'll look at the eyes in the dark to see when
Oh,
you take
wow.
out visual fixation, what they do. And again, that's more of like the VNG realm. But in here, that's pretty much, within an hour, we have that brain mapped out and ready to go. So
It's really cool. Well, again, thank you so much. This
yeah,
was
of
great.
course.
Oh,
Of
wait.
course, Lane. Yeah.
Sorry, you guys. Just got a
Yeah,
question.
do it.
Perfect.
Miss Penny wanted to know, how do you do a gait analysis? If there is a shuffle, can that be changed? Is there a simple way to change it?
I think simple is the hardest part of that question. In terms of our gait analysis, it usually is observational. There's actually some technology, some of our neuro PT clinicians will use that, where you can actually use a video image and you can put dots on their shoulder, elbow, hip, knee, and ankle, and watch them as they walk across screen, and it'll map out their stride length. It maps out how they move. If there's a shuffling gait that is associated with the patient, we have to look and say, well, which is the shorter stride length, right? Why are they shuffling in the first place? We know where these things come from in the brain, but more importantly, is there a sidedness to that presentation? Is there an arm swing that's been lost? Is there a forward head posture? And we kind of pair those together to see, A, what part of the brain is the biggest piece of that patient's puzzle that should be worked on, and more importantly, see if it can change. The way we do that is with therapeutic trials, which means we run some eye movements or run a sensory motor technique or whatever it might be, and down the hall you go, and we recheck. The half-life, without getting too sciencey, right, of that brain's neuron is nanoseconds, which means a lot can change in a few minutes if it's done correctly. So again, that's where we do these trials in real time to say, was there change? Was it the appropriate change that we wanted to see? Did anything get else, did anything else get worse? And if not, awesome, we're gonna do that a few extra times. If it sticks, great, we'll do a little bit more, have them do it at home, whatever it might be. In terms of the easy fix for shuffling gaits and freezes, things like that, a lot of the general things we recommend goes more into at the home, right? Taking out the rugs that are on the hardwood floors, or you can put stripping, some visual cues on the ground, things like that. There are certain canes for shuffling gait that actually work very well, like an L-shaped cane, that as you walk, you step over that each time. And we know with that area of the brain, having that visual and motor cue can allow that brain to rehab itself. So if you've ever seen like the warning strips of yellow and black tape, right? You can run those along a hallway, and that visual feedback allows that brain to pick up a little bit more of its environment and reduce the shuffling to a degree. Again, that's not for every patient, but those are pretty easy and inexpensive things that we can have patients try at home to see if they can get that day-to-day improvement, or if nothing else, an improvement in their quality of life. But great question. Yes, gait analysis is tough. I will say I am not the best by any means at it, but we know it's a very, very important piece of the puzzle. So.
Thank you, Dr. Case. Thank you,
Yeah.
Ms. Lee, for your question.
Absolutely, Penny. Absolutely.
Well, if no one has any more questions, I will definitely send you Dr. Case's information so you can contact him directly. And I would like to thank you all for coming. And thank you, Dr. Case, for, coming through and speaking to the group.
Of course. Thank you. Hopefully we're all able to glean a little bit of it. And again, if there's any questions, I'd be more than happy to answer them. Feel free to reach out via email, phone, whatever it might be. No problem at all.
Thank
Right.
you.
Thanks, everyone.
Wonderful. Thank you.
Have a good night.
Have a great rest of your day.